Again, welcome to everyone here. This is the second installment of our webinar series brought to you by the European AIDS Treatment Group. I am Nicoletta Policek, a very proud Executive Director of the European AIDS Treatment Group, and I'm absolutely thrilled to be here to talk about women aging with HIV. I'll tell you more about the webinar in a minute. In the meantime, also, we're allowing even more people to join us. And I can just start with some ground housekeeping rules. The event will be recorded and will be available on the EATG YouTube. I think during the presentation in particular, make sure that you make yourself mute and write any comment, questions, any feedback you want to offer in the chat. My colleague Natalia will be monitoring the chat. And if you have any specific questions, or Natalia will then pass all the questions to me, and I will address the questions or the comments you have raised with our speakers at the end of their presentation, at the end of the final set of presentations. As I said already, make sure that you are on the right channel, meaning either English language or Russian language. There is the opportunity for you, if you don't want to be seen, and also if you don't want to share your name, write a message, a private message to my colleague Natalia. She'll be able to help with this. If you're experiencing any technical issue, please contact my colleague Apostolos. As long as you're not asking me for anything technical, you'll be fine. My colleague Apostolos is a genius, and his email address is here, but you can also reach him in the chat. Okay. This webinar is, as I said, part of a series. And we want to draw attention to the key consideration outlined in the Glasgow Manifesto. So this webinar, you could consider almost an outcome of a project which is called Aging with HIV, the Glasgow Manifesto, a platform for change, which is developed by the EATG, but supported through a grant by Merck, Sharp and Dome. The duration of the project we started in April 2024, and the project will last until November 2025. The main aim of the project is to enhance understanding of the unmet needs of people aging with HIV across countries. To be more specific, we had the opportunity to look at 7 different countries in the WHO Europe region, and ways to address the unmet needs of people living with HIV. This project builds a consensus on measures to be taken at a sort of healthcare system level, but also care providers level. And we had the opportunity through this project to review the implementation of policies and programs compared to the recommendation contained in the Glasgow Manifesto. I'm really happy to say that this webinar is exclusively dedicated to women aging with HIV. And we will try to explore the unique experience women living with HIV, aging with HIV, encounter through their journey. We will also highlight a gender transformative approach, highlighting that gender norms, roles, and power dynamic profoundly shape the realities of women living with HIV as they age. We will hear soon from our esteemed speakers about aging with HIV when it comes to women, but I want to highlight very, very briefly, I promise, the importance of a gender transformative approach. In health policy, a gender transformative approach goes very much beyond simply being gender sensitive or gender responsive. My interpretation, and I hope we will agree with this interpretation, is that we need to actively seek to address and challenge the root causes of gender inequality, and so the work we do contribute to health, that contribute to health disparities. Instead of just accommodating gender differences, this approach aims to transform harmful gender norms and roles and power dynamics, as I said. For women aging with HIV, and this is the only point I want to make before I leave you to the esteemed speakers, this means shifting the focus from individual responsibility for health to acknowledging how broader societal and gender contexts impact the experience of women aging with HIV. So in another word, a gender transformative framework in health policy would, for example, challenge patriarchal norms that limit women's autonomy in healthcare decisions, advocate for policy addressing the social and economic barriers such as poverty, experienced often by women of all ages, but specifically when they're aging with HIV, and also caring responsibilities that disproportionately affect women. And finally, integrate a gender lens into clinical research and medical guidelines. And I'm particularly passionate about this to ensure that unique needs of women, and we will hear soon about these needs, including menopause and comorbidities, are properly addressed. While aging with HIV affects women globally, those in the US, Europe, and especially in Eastern Europe and Central Asia face different challenges to different healthcare systems, different social norms, but also different legal frameworks. So we will take today a deeper look at these regional disparities to better understand and address the specific gender implication within this context. It is my great pleasure to now introduce the speakers. I'll start with Linda Scruggs. She will be our first speaker. She asked me to be very brief. So I'm just going to say Linda is an amazing, passionate, caring activist. She's an educator. She's a change maker. She has been involved and caring for the HIV community for over 34 years. We'll then have the pleasure of meeting Professor Marta Bofito. Marta Bofito is a consultant physician at Chelsea and Westminster Hospital and Imperial College in London, in the UK. She's the clinical director of HIV, sexual and gender health, dermatology at Chelsea and Westminster Hospital. Again, she's another amazing woman. There is a slightly change in the order of speakers, so the next speaker after Marta will be Mira Saurabanyeva. Mira is a gynecologist and the vice president of the Kazakhstan Association on Sexual and Reproductive Health. She holds a master's degree in public health, and she has more than 25 years experience in the field of sexual and reproductive health. And then last but not least, Professor Cristina Mussini, full professor of infectious diseases at the University of Modena. Again, she's another change maker, like the other speaker before her. She has 35 years of experience in HIV, and she has managed to do wonders. I'll leave you now with the first of our speakers, and I want to thank you again and welcome you again. Linda, the floor is yours.
Thank you very much. Can everyone see my screen now that I'm sharing? Perfect. Thank you very much for that kind welcome, and thank you for the invitation to be here. As noted, my name is Linda H. Scruggs. I am the co-executive director at Ribbon, a center of excellence. We're located in the United States. And my charge today is talking about AIDS-related experience for women living with HIV in the US. I will share with you, I am a woman diagnosed with HIV for over 34 years and have worked in HIV since 6 months of my diagnosis, at Johns Hopkins Medical Center for 10 years, and nationally in the US with some global impact for the last 25 years. I'm excited to be with you today. My role today really is coming from Ribbon Center for Healthy Living with HIV. And we receive funding from Gilead Sciences to be the host of the Center of Excellence, which oversees and support 23 other organizations in the United States supporting HIV and aging across 50 plus, across the identity and lifespan. Today, I'm really going to be talking to you about women. As it is noted, these are the partners. I will give a disclaimer, two things. I'm from the South in the United States, and we tend to speak fast. So if I'm speaking too fast, please do something so I can make sure I slow down. And the other thing I would invite you to do as a trainer, educator, I will be asking you and asking you to do assignments, and that we have an interactive time together. So I'm going to keep going. I wanted to start talking about health disparities. And I really want to focus first on health equity, which is a state which everyone has fair and just opportunity to the highest level of health itself. I wanted to start there because we at Ribbon, particularly even me personally, don't necessarily know if all women get this space. And it's around achieving this, which requires ongoing societal efforts to address historical as well as contemporary injustices, overcoming economical, social, and other obstacles to health and health care, and eliminate preventable health disparities. So I started with health equity because this is the grounding, this is the pillar of what everyone should have. Everyone should have. But we also know that in the US, because of the HIV disparities, particularly how it impact gay and bisexual men, women with HIV are often underrepresented in the HIV conversation, despite we continually are representing between 23 to 25% of people living with HIV. We still are not part of the primary conversation and focus in the United States. I will also want to note that women are less likely to perceive themselves. A term we use in the US that we use at Ribbon is HIV possible. We definitely know we take away as often risk, because it's HIV possible, is the way we see it, and not necessarily folks think that they've done something to put themselves in harm. But we do know that people are HIV possible. And often because of this, the information that they need to get from their providers and their communities are not necessarily seen, provided, or available to them in those spaces. Just to keep us going, in the United States, women living with HIV, like most countries abroad, face significant financial burdens. In the US, most of our data and focus and information goes towards women of low or poverty level. So a lot of the data we would have would not look at middle class or different class levels. Most of our data is focused on persons in low income or it's living below the poverty level. We know that HIV stigma is really true, and it is very true when we're talking about income and access to income, access to the services that they may need, whether employment services, volunteer, as well as education. Fewer opportunities for employment are available to women, particularly if they've disclosed their HIV status in most cases, and particularly in the South, the level of stigma among the Southern parts of the United States, still there's quite much discrimination in those areas. We still experience discrimination in healthcare services, but also I'll say again, in our prevention, and how do we really change the concept of prevention to care? Prevention, HIV prevention to us is as important as it is to care for women, because we do know, globally, we know that HIV is a preventable disease. But those women who are aging, how do we do that? In the United States, much of the existing HIV research is not focused at women, it's focused at men. And there are several coalitions and individuals who have been working, trying to get this experience changed to a more interpersonal culture and addressing financial as well as structural factors that impact women who might find themselves at risk. Finally, definitely stigma varies based on gender, but it has been reported constantly over. This is something that has not changed. Women and transgender individuals with HIV report higher levels of stigma than men. And that is a piece of data that has not changed since we've been asking this question here in the US. This is going to be a slide. I'm going to ask you to participate with me in the chat. I'll start at the bottom of the slide. When you're thinking about some of the challenges that may experience women in their 50s and 60s, I would love for you to drop them in the chat. And how can providers improve their care for women in their 50s and 60s? Managing chronic conditions with the life spaces that many women in the US, most women in the US, other chronic diseases in addition to HIV. So really managing the life and aging of persons with HIV, we're finding challenges there. I know some of our colleagues will be talking about menopause. I won't go into that, but menopause and its interactions and treatment interactions. We'll talk about that, I'm sure, later. But that's a key piece when you're talking about women over 50, as we talk about women across the lifespan. So we have a group we call the lifetimers, those people who were born with the HIV transmissions, and also seeing how we see early menopause is happening and symptoms related to HIV. Long-term ART treatment, side effects with women already having osteoporosis and other bone and bone density issues, kidney issues, women navigating what does long-term ARTs look like and how do they fit into their life when they're already challenging some other areas. I will not minimize the racial inadequacies worsened by diagnosis, treatment, access, and our health outcomes itself. I see a couple of folks have gone into the chat. I think we believe is one simple way that providers can improve care. And that really is going to a very individualized care system and not bucketing the experiences, all women or all clients, really talking with and spending time, not just knowing your client, but hearing your client, spending that time talking with her, spending that time in that. I'm gonna spend a couple of slides around racial disparities of women of color in the United States. When Black women are 10 times more likely to be diagnosed with HIV and 8 times greater than that women who are white women, forgive me, as well as HIV mortality rates among Black women are still very high. It is the 6th leading cause of death among Black women in the US. And like, why is that happening? That means there's great health disparities that at this point, we're still at 6% of the highest leading death cases in the United States. Again, you guys see the slides. I'm gonna keep going so I don't take up time. Social and emotional experiences. Women still report dual stigma. As they're aging, HIV was its own stigma. More and more, we're having stigmas around ageism and sexism. I won't go very much into, I'll say this piece. I just left a 4-day conference literally yesterday, the US conference on HIV and AIDS. It's the largest conference in the United States on HIV. And one of the things, because of many of the things that are happening in our current administration in the United States, the large impact of what's happening in the LGBT community, and many people feeling that it's a male persuasion in the LGBT. Women are having greater sexism issues in trying to identify and find places of support than they had previously, and women are reporting to be more compound. Increased isolation and loneliness. Again, as we age, loneliness and isolation is part of that space anyway. Underreported, under care, and under treatment of mental health needs of such issues of depression and anxiety has escalated as we find that women are aging and often aging alone. The need now, because of the aging, in the United States, I call us the baby boomers of HIV. We're the largest generation of individuals that have aged at one time. This was happening right now. And we find that many women, again, are becoming the caregivers, not just on possibly their family members, but other persons who are living in isolation or who don't have family support in that space. So again, how does that lead into ongoing spaces? We talked about financial insecurity already, access to healthcare, because again, most of the populations we're working with are underemployed or living in poverty levels. And how do we really build out workforce development opportunities to be able to strengthen individuals who have the abilities or the desires to work? Housing insecurities, that's a global issue. Social economically, housing in the US is, if you live in an urban city, for housing for one-bedroom apartments, you're talking $2,000 to $3,000 and $5,000 per month in many cases. And in the South, it may be a little cheaper, but again, it still does not meet the economical space that allow women to have security in housing, in particular if they are single, widowed, or not partnered with someone. And again, the disparities among Black women of color, again, greatly. I'll send you to the chat again if you have a moment to think about the barriers that hit aging women the hardest in your communities, in your countries, and what interventions could help. One of the things we do at Ribbon, we have recently launched a workforce center where we're not teaching people how to get jobs, we're teaching people how to be re-careered as they're aging and helping them navigate to career services that do allow and take away those um, ageisms and stigmas from HIV, working with organizations and corporations around how do we re-employ or we help women who may have not been traditionally in workplace settings, how and what can they do to supplement and support their incomes is a big part of some of the work we're doing here at Ribbon. My almost last slide is just a closing reflection. When we're thinking about women and aging in the US, it's medical, it's social, it's structural, it's racial disparities. Aging women requires compassion, advocacy, and racial equity, and systematic change has to happen. For us to get to ending the HIV epidemic in the US, for us to get to the place where health equity is a real space, we have to look at systematic change in the midst of all the things that are happening here. I'm going to stop now. Thank you very much. I know there may be questions and answers later, and I thank you for the opportunity to be with you today.
Thank you very much, Linda. That, as always, an inspiration to hear what you have to share with us. And I'm sure there will be so many questions, but for interpretation purposes, we leave all the questions at the end. And it is now my very great pleasure to ask Professor Marta Bofito to follow Linda's presentation. Thank you.
Thank you very much, Nicoletta, and I hope you can see my slides. So it's a great pleasure to be here and to be able to share some of the experience of the care deliverer in the HIV settings and around, and discuss complexities around women's health, women living with HIV health. So let me move the slides. Perfect. So I'm just gonna cover over the next 15 minutes, and then obviously I'm very happy to answer questions at the end. Some key elements of what we know today about aging and HIV in general and in women. So I'm going to mention frailty and briefly discuss that. I'm going to talk about menopause. And I know that, again, my colleagues after me will talk about it more. And then obviously a little bit of mental health and drugs. So, As Linda said, the population living with HIV is aging, and a high percentage of people will be above the age of 50. And as the people living with HIV are aging, there is a complex interaction that is created between HIV itself, long-term use of antiretroviral treatments, natural aging, that is something that unfortunately none of us can escape from. And all of this results in some health concerns, in a set of health concerns, and these do include frailty and geriatric syndromes, because we know that people living with HIV who are aging are at a higher risk of multimorbidity and polypharmacy. So just so that we are all on the same page, frailty is defined as a multifactorial syndrome, and usually it manifests itself by weakness, decline in physiological function, so slowness, really, diminished strength, fatigue, and it leads to a state of vulnerability and decreased resilience to environmental stressors. So we know that people with HIV can be affected by higher levels of frailty and maybe even earlier in life, especially if they experience the low CD4 count and also prolonged periods of therapy that might have increased, some aspect of inflammation. And again, this is very important because we are in the context of being unwell. And I think we're all here to see what can we do to improve the quality of life of people aging with HIV. I think us, healthcare providers, have the responsibility to contribute to improve the quality of life of people aging with HIV. And so again, this is other, definitions of frailty, and showing you that it can manifest itself with weight loss, fatigue, low activity level, slow gait, weak grip, and so on. Now, the consequences of frailty, so what does this all mean? It means that people are at higher risk of falls, they might not recover from illnesses and falls, or take a long time to do that, show greater functional impairment, hospitalizations with worse outcomes, and also higher mortality. So this is why we are trying to identify and prevent frailty in people aging with HIV. One of the most important studies in the literature, I think, is the GEPPO study. The GEPPO studies come from Italy, from Modena, from Professor Giovanni Guaraldi, and he actually wanted to understand why people with HIV age with a higher burden of multimorbidity and polypharmacy. What can we do to manage it, to prevent it, to improve it? And the GEPPO study showed that actually people with the longest HIV diagnosis time, so with older HIV diagnosis, and again, that maybe were exposed to older antiretroviral treatments or were off treatment for a prolonged period of time in the older days, are those that are at higher risk of multimorbidity and polypharmacy. And this is really, really important because it needs to be discussed. It needs to be talked to. The person living with HIV in the clinic, in front of the healthcare provider, should have that space to have the conversation about their health in general, and what are their risks and why, and they should be talked to and they should be listened to. And this is a very, very important aspect. So what about women in particular? Sorry, that was a little bit of an introduction about people with HIV in general that obviously included women. Now, what about women in particular? So women have some specific additional considerations, such as tolerability of medications, barriers of accessing treatment in some populations, barriers to adherence in some populations of older women, increase of comorbidities and polypharmacy. We're going to talk about it in a minute. Potential early onset of menopause. I'm going to stop here for a second and I say potential early onset of menopause. And I have to be honest that for me, this is a little bit frustrating because I would like to really know whether the early onset of menopause is a real concern that we should have for women aging with HIV. But the research is incredibly poor, and we don't really know whether this is something we need to be concerned about. And again, I would like to link this to what Linda was saying before me and underline that the research around women aging with HIV is very poor, and there is so much more that we need to learn to be able again to support women aging with HIV and contribute to their quality of life. Obviously, we also have concerns regarding drug-drug interactions between co-medications, between antiretrovirals and hormone replacement therapy or HRT, and also the elevated symptom burden that we might observe during menopause. So just to keep going on this, there are already within HIV, people living with HIV seem to present more frequently with certain comorbidities such as bone disease, cardiovascular disease, cancer, liver disease, renal disease, cognitive decline. And very interesting, these comorbidities are very relevant and very important in women living with HIV, because when you enter the menopause phase, we know that bone disease, cardiovascular disease, and certain nervous system disorders can become a matter of concern. So we have people that might be at risk of certain comorbidities because of HIV, but also because of the aging process and the menopause. And this is indeed very, very important. And prevention and discussions and communications and talking about it is fundamental. And I'll keep saying this because I know that in our HIV outpatient settings, we don't talk about menopause enough when we see women. It is fundamental. Menopause can be terrifying. People can feel very unwell during menopause, and they need to be supported. They need to be told it might not be HIV, it is menopause, and they need to be, again, supported through this difficult period of life. So the symptoms that are a consequence of the loss of ovarian estrogen production can be quite debilitating and can lead again to a certain numbers of comorbidities like cardiovascular disease, bone disease, diabetes, hypertension, as we mentioned, but also really affect the daily life. And they can also lead to an increased risk for metabolic syndrome, which means, you know, hypertension, obesity, altered lipid metabolism, which are all important comorbidities that also can develop in people with HIV. So, as I said, the symptoms that can associated to menopause or pre-menopause or menopause, post-menopause can start at any time. And there is no really cutoff age at which symptoms begin or end. And this is why we need to have the conversation with the women that we see in our clinics, in our offices, because it is incredibly important that we consider the possibility that the symptoms reported are menopausal. We know that menopause is associated to depression, and this can remarkably affect, indeed, the quality of life, and again, the isolation and the different aspects of health. Now, there are remarkable benefits of hormone treatments, and these are very important to be discussed in clinics. We at Chelsea Westminster Hospital in London, where I work, are very lucky because we have some wonderful colleagues in the HIV service that have developed a menopause and HIV clinic for women who come to our service. So they are offered HRT, and they can discuss the benefits, the risks, and they can be prescribed HRT and started with the support of the HIV clinician. The benefits about the quality of life are enormous, and need again to be highlighted, discussed, and hopefully the fear of maybe women to having to take more medications or having to experience side effects are overcome by honest and thorough discussions in the clinics. So whether menopause is different in HIV, we still don't know, and I know that people after me will talk about it a bit more. And whether people living with HIV, women living with HIV, have menopause earlier, it still remains unclear. But what we know is that women aging with HIV that are experiencing menopause are offered HRT less frequently than women without HIV. Maybe it's the fear of drug-drug interactions, maybe it's poor communication, but this is something that shouldn't happen because women are offered hormonal replacement therapy to feel better and have a good quality of life. And again, I wish we knew more about what HIV does to menopause and what menopause does to HIV. At the moment, we know that they have some common features and that we don't discuss it enough, and that we have to talk about menopause to all women that come to clinics to make sure women are comfortable to talk about it so that we can help them. But we don't know very much whether it is HIV actually leads to an increase of symptoms, an increase of psychological symptoms, including depression. We don't know whether menopause can actually affect adherence to antiretroviral therapy, and whether there are menopause affect mental health more in people living with HIV. So as I said at the beginning, more research is indeed needed. I'm going to stop here so that people after me have time for their presentation, and I'll be happy to take questions, as I said at the end. And thank you so much for your attention.
Thank you very much, Marta. And now I'd like to introduce our next speaker, who is Dr. Mira Saurabanyeva.
Hello, good evening, good afternoon. I'm glad to see you, and I'm very thankful to organizers to participate in this webinar, because for me as an obstetrician and gynecologist, this topic is very interesting to me. There were several projects in Eastern and Central Europe and Central Asia, and these projects were aimed at screening related to the breast cancer and cervical cancer. And I was consulting online for several countries where this project was conducted, and approximately half of women participating in this project were over 45 years of age, and they were concerned about menopause. But I listened to the colleagues, and I'm glad that some studies are conducted in Europe, America, in Africa, but unfortunately not in Eastern Europe and Central Asia. we practically do not have similar studies or such studies, and that is why I will probably talk more about why this topic is relevant today for our region, because you can switch to slide 3, because if you look at the most recent UNA statistic, you will see that the number of new HIV infection is reducing and the number of AIDS-related deaths is decreasing. This is related to the fact that more people have an opportunity to take ARV therapy. The quality of life is improving. Lifespan is increasing, and at the same time, women have other problems, are facing other problems. If you look at the global statistics, we can see that women and girls account for almost 50% of all cases, HIV cases, and 53% of all people living with HIV were women. And as Marta said, that almost 70% of people living with HIV will be over 50 years by 2030. I cannot give you any information related to the older women and their access to menopausal hormonal therapy in Eastern Europe and Central Asia, because, as I said, there are not very many studies. 2 or 3 studies were conducted, and the data are contradictory. Next slide, please. And I would like to show this study. My colleagues, as my colleagues told, women of the older age with HIV status experience symptoms of menopause harder than women without HIV. And you can see it on this slide that women with HIV, these lines are dark, and without HIV, they are white. And these are related to psychological problems, anxiety, depression. There are some problems with the bone density, with drug resistance. But at the same time, this problem is rather relevant. And taken into account that I'm a gynecologist, I would like to show and tell you about the changes that are taking place in the female body, what should we focus on, and refer them to the doctor. On this slide, I would like to show you the stages in women related to the decline of reproductive function. There is some time for premenopause, perimenopause, and the menopause itself, 12 months after the last menstruation, and everything after this is postmenopause. This period, in this period, a woman loses her reproductive function and cannot become pregnant. There is a stage of aging, which is called straw 10 plus, used by the doctors. And when the doctors diagnose menopause or perimenopause, they refer to this diagram. Next slide, please. And if we look at this slide, we will see that women with HIV should be focused on these three periods: perimenopause, premenopause, and menopause. But there are colleagues who say that menopause can start earlier than in women with HIV-negative status. Why it is important? If we talk about the lack of menstruation for 12 months, it is preliminary ovarian insufficiency. This means that women will have enough time. They will be able-bodied, but they may have cardiovascular problems or bone density, mineral bone density can be lost. And that is why it is important to start HRT in time, not to lose this period. Some of these periods are characterized with the menstrual cycle variations. So females experience sweatness, insomnia, fatigue, and these problems only exacerbate, only become stronger. And some women believe that if they do not have menstruation, they already have menopause. But no, they need to think about these changes in their menstruation cycle, and they should immediately visit a doctor and talk about it. And there are special scales which are used, and it is important to discuss it with women, to discuss the menstrual variations and the hormone indices, because sometimes these changes are not so visible, but sometimes we observe hormone fluctuation. Sometimes the level of hormones is higher, sometimes it is lower, but at the same time, the woman feels more or less well, but the changes already started, because ovarians start working worse, and they do not produce hormones anymore. Next slide, please. On this slide, I show you three stages: premenopause, when reproductive function is preserved. Onset of hormonal fluctuation starts, so it can go up and down. Symptoms are mild, and it usually happens in the age of 40, 45 years. If it started earlier, it is preliminary menopause. Why it is important to understand? If a woman does not want to become pregnant, she should use contraceptives, because in this period it is easy to become pregnant. Next stage is menopausal transition, when the menstrual cycle is irregular, and women complain about blood discharge, which is bigger than usual, marked hormonal fluctuations, and the main symptoms are hot flashes, night sweats, decreased libido, sleep disturbances, emotional lability, edema, and some events related to genitourinary syndromes. They show changes in the vaginal system. It can last from 40 to 45 years. And next stage is postmenopause. After the last menstruation, 12 months passed. And this period is called postmenopause. These systems become worse. And so we can see the signs of the atrophy, of the vaginal atrophy, dryness of vagina, painless sexual contacts. All these symptoms are related to postmenopause, and all the risks were mentioned today: osteoporosis, metabolic syndrome, cardiovascular diseases, And women often say, I do not eat anything harmful, I drink only water, but they have a central obesity as the so-called life circle around me, life-saving circle. And but women do not understand the reason for this. Next slide. I would like to speak a little bit more about recommendations about menopausal hormonal therapy. And colleagues mentioned it already. It is a rather complex group of patients because there are many factors that influence the aging, age-related factors, and hormonal therapy, menopausal therapy. And the most recent guidelines by EATG tell us that we need to check women for these menopausal symptoms after 40, 45 years. And it is good if the specialists, medical specialists, obstetricians and gynecologists should screen women in this period. And because this period is rather complicated and it is related to many other things. And when we talk about menopausal hormonal therapy and HIV, there are not any specific differences between the prescription of the hormonal therapy, but it should be initiated before the age of 60 and maybe within less than 10 years of postmenopause, because we need to use this window of opportunity, because without it, the HRT can bring negative results. There are specific regimens when the cyclic hormonal therapy is prescribed. Sometimes monotherapy with estrogens is prescribed when women are after 50 in postmenopausal period. And when we talk about some surgery in women, if she was operated on ovaries, we need to prescribe specific drugs, and we should take into account that there is a group of women for whom it is better to prescribe transdermal hormonal therapy, not pills, because it helps to reduce the contraindications, and these transdermal estrogens combined with the progesterone are preferable. It is important to follow up this women. First time this woman should visit a doctor 3 months after the beginning of HRT for a doctor to understand whether this medicine is good for this patient. If it is not, a doctor should talk to a woman and discuss what happened during these 3 months and change the tactics and maybe change the medicine. There are absolute contraindications and certain contraindications which exist with all treatments. There is a group of women for which it is not recommended to prescribe hormonal therapy. Unfortunately, it is not often scientifically proven, but some phytomedicines or some herbal remedies, some SSRIs can be used in such cases. And it is very important to ensure oncological screening, cancer screening for women. We are talking about it. Our cancer specialists and gynecologists talk our patients all the time that it is important to be screened for cervical cancer, for breast cancer, and it is recommended to do once every 3-4 years. And for women with HIV, it should be done more frequently. Also, I would like to tell you that in our region, we have certain problems. First, I already mentioned, practically there are no studies of women in the age group 50 years and older. Second, we do not have clinical protocols that would describe the prescription of menopausal hormonal therapy for women with HIV who receive hormonal therapy, menopausal hormonal therapy. And there is a site I will show you on drug-drug interaction, and you can use this website to see which HRT medicines and ART medicines can interact between each other or can work with each other. Also, I would like to tell that some women themselves not often have this information about changes in their body. They simply do not notice them or do not pay attention. And also, it is important when I talked to our patients, female patients, and consulted them, it is important to ensure a psychological support and peer support groups. It would be helpful, very helpful to women. And I always mention it during the consultation. And I would like to present you two cases because I'm running out of time. Two cases of women. I had two women. One woman was 45 years and she came to me and complained about insomnia, shallow sleep, night sweats that started suddenly. She could not understand why it happened. She thought that it was related to antiretroviral therapy. She remembered that when she was diagnosed with HIV, she had similar symptoms. She consulted a doctor at the AIDS center. All CD4 count was good, viral load was high, undetectable. And only then a doctor decided that she has perimenopause and she recommended her to visit a gynecologist. And several months after this, she came to me. I offered her hormonal therapy, taken into account other chronic diseases. And she told me that she had anxiety, she was nervous, and it was very difficult for her. The second case, a patient, 47 years old, she hasn't had menstruations for 7 years, but previously she was using drugs. Then she was switched to methadone therapy, and then she had minor bloody discharge and vasomotor symptoms, heat flashes, sweatness, and she became nervous. Nervous. It was difficult for her at work, and it was a new job for her, and she was afraid to lose this job. Now she is being examined, and we are trying to select a menopausal hormonal therapy for this patient. In principle, this is the end of my presentation, but I just want to say that it is very important to integrate, to invite all specialists, especially in our region where we have AIDS centers with multidisciplinary teams. And in Kyrgyzstan, in other Central Asian countries, these centers work very well, and it is important for these centers to refer our patients to the special treatment. We need to educate healthcare workers, doctors, because when we, for instance, have meetings with gynecologists, we explain them what U equals U means, we provide other information, but unfortunately, many doctors are unaware of all these things. And at the same time, many of our patients turn to these AIDS centers and the primary healthcare centers when they reach rather old age. Thank you for your attention, and I'm ready to answer your questions in the end of this webinar.
Thank you very much. And now I'm asking Professor Cristina Mussini, hoping that
Yes,
yeah,
I'm here.
she is here.
Yeah,
Okay.
I have to share my slide. Uh, Okay. So, we are talking about the complexity of women health. These are my disclosures. Why women? I want just to, sorry, okay. This, why women older than 50 could be left behind? There are many reasons. I know that Marta already talked about them, so I will not repeat them, but low perception of HIV risk, managing HIV and other health issues is very complicated I mean, doing it together, access to services, stigma and discrimination. And we have also other issues that we have to improve in women with HIV. The knowledge of U equal U. Most MSM know about U equal U. This is not always the case about women. We have to talk about cancer and the risk of cancer and precancerous lesion screening. We have to talk about vaccine, menopause, also Marta talked about menopause, sexual dysfunction, isolation, economic instability, difficulties in accessing healthcare, stigmatization, but also partner violence environment. Talking about menopause, just to say that I turned on the 5th of September 5th, 63. And when I started working in this field, I was actually 34 with a wage. I started with with the salary at 34. Without the salary, I was 28. And all women that we were following in the clinic, they were all very young. But now the situation has completely changed because the number of women in menopause has increased dramatically. And we are talking also not only of menopause, but also of early menopause. There is an estimate of about 10% of women aged below 45 that go in early menopause. And we know that the menopause has impact on bone mineral density, has impact also on the mood, on psychiatric health and depression. So it's important as clinicians to consider women as a whole. And menopause is just a transitional period that should be taken into account also by infectious disease specialists and not only by the gynecologist, I have to say. Okay. The most important thing in menopause is the fact that we should prescribe more hormone replacement therapy. Why this? Because hormone replacement has been associated with a better intima media thickness, so a decrease in cardiovascular risk. And we know that, I will talk also about it later, we have to prescribe many things, but I think that since we are in an EATG webinar, I think that also women with HIV should advocate to have prescription of these very important drugs. So I think that hormone replacement therapy is something that we have to ask about, even if we don't have symptoms. Among non-AIDS comorbidities, we know that women and men have different trajectories, either in people with or without HIV, but we see that there has been an important increase in survival, so in life expectancy, that has almost reached the one of the general population. This is more true among men than among women, because women in the general population live much longer than men, probably, or also because women are more fragile. They belong to different groups that could be more fragile. And when we talk about the life expectancy, we have always to take into account the problem of late presentation that has a huge impact on life expectancy. It's like a scar that never heals, because the problem is that you can see that it depends largely on the number of CD4 counts at starting heart. So when it increases, the difference with the general population is almost nothing, but when the CD4 count are very low, and we have a high rate of late presenters among our population, the impact is dramatic. Okay, not only the life expectancy, but also how people live, and we know that living without HIV means that you develop comorbidities at a much older age than people with HIV, because people with HIV have this, is what it is now, HIV, that is a chronic inflammatory disease, and this chronic inflammation really decrease the time free from comorbidities. And this is very clear, for example, in this data from a French HIV cohort, the COCOVID, that shows that women have even a higher risk of dying of comorbidities than men. So this is something that we have to take into account, because we have this idea that women are protected from many comorbidities, which is absolutely not the case. And we have to be aware that comorbidities have an impact on women's survival. So it's not just that they are annoying, that there is polypharmacy, but there is an impact on women's survival. And you see that even among cardiovascular disease, the risk is the double for women compared to men. And this is different from the general population, at least until the age of 60, because after the age of 60, when you, even in people without HIV, you have a risk that is comparable between men and women, because the women lost the protective effect of estrogens. But you see that even the stroke is more frequent. So all the cardiovascular disease. We have to take into account cervical cancer, but I would say cervical dysplasia, because all women with cervical dysplasia should be screened for anal cancer. When they have HPV, they should be screened for anal cancer in any case. I always cite Farrah Fawcett, because for someone who is my age, we all remember Charlie's Angels, and she died of anal cancer. So it's not only people with HIV, but it's just all women could have it. So we don't have to forget that we have to screen our women for both cervical and anal cancer. This is a very recent paper showing that maybe if we discontinue the screening above 65, it's not correct. I mean, we should continue to screen even later. We know that there is a cardiovascular risk, as I said, it is higher in people with HIV, and it's very important to look at the data the reprieve studies showing a protection of the prescription of pitavastatin, of a statin, not only for the first myocardial infarction, but also first myocardial infarction and death. And this is, it was just, just because they were living with HIV. They didn't have a higher cardiovascular risk. They had a low and middle cardiovascular risk. So it's important to underline this. And also the effect on reprieve was independent from the effect on LDL. So that's why all the guidelines, here there's the BIVA, the HHSS, EACS, and the ESC, the European Society of Cardiology, show that all people with HIV older than 40, they have to start statin. But we are at a very low level of prescription, and in women is even lower. This is the other guidelines. The last part is something in a way visionary, because this is Cher that was singing this song, that if I could turn back time. Is it possible, since we know that HIV is associated to accelerate aging? Is it possible in a way to turn back time? We can because we should request, people with HIV should request for more hormone replacement therapy. As I told you, this study shows that it decreases about 40%. You see 43% lower prevalence of plaque in women postmenopausal women who were taking hormone replacement. And it could be any hormone replacement, not just, it could be even the topical gel. So this is something very, very important to take into account. And then request and take statins, because these are data from Giovanni Guaraldi, and taking statin not only decrease the cardiovascular risk, but also decrease the frailty trajectories. So this is very, very important to consider also about frailty. And the real novelty is about semaglutide. So the GLP-1 agonists, these are drugs that once weekly, taken once weekly, they could determine a decrease in fat. So, and especially in lipohypertrophy. You can see that the decrease was very important because abdominal total adipose tissue minus 15%, abdominal visceral adipose tissue that is even more relevant for risk as a risk factor for cardiovascular risk is minus 30.6. So it's very, very important to see that there is a decrease in this fact. And why it is important? Because fat is a tissue that is alive, it's active, is an inflammatory tissue. And so decreasing the fat, it has been shown to determine a decrease in all inflammatory markers. And then there is this last paper that was first presented at CROI this year, is a randomized study to see if we could turn back time, if we could work on epigenetic clocks. And what has been shown is that there was, while in general, people with HIV show an increase in the epigenetic age, that is the methylation of the DNA that is associated with aging. So you have an increase of this, but if you use semaglutide, you have a decrease in this epigenetic clock and in this epigenetic age. So in a way, we can turn back time. Obviously, it would be very important to share all these novelties and to reach this level of taking care of our women with low and middle income countries. And this should be our goal. But this is what we hope for us and for our women with HIV. This is Jane Fonda that is really passionate and still good looking at 87 years. So in conclusion, women living with HIV are fortunately getting older worldwide. It is extremely important to consider all their different peculiarities, from the physiological ones as menopause to the psychological ones. Our goal is not to witness passively, but proactively fight aging in women with HIV. Thank you very much.
Wow. Thank you very much. Thank you, Christina, but thank you all our speakers. It's just been such an inspiration. We don't have as much time as I was hoping to have, but your presentations really taught me a lot. I have a series of questions in the chat that Natalia kindly translated for me into English. But I was wondering if amongst those who are in attendance, is there someone that would like directly to ask a question to our speakers? Otherwise, I can kind of group. Most of the questions are, there is Memory who very briefly will ask a question. Thank you.
Okay, thank you all for the wonderful presentations, greatly appreciated. I'm just interested in finding whether the non-hormonal HRT or, it's mainly HRT, would that work for a woman who has had cancer, like a cancer that's sensitive to hormones, hormonal cancer like estrogen and progesterone? I don't know if I'm saying that correctly. I just wanted to find out how that works with non-hormonal HRT.
Thank you, Memory.
Shall I start, and then maybe the
Yes, please.
gynecology, Mira, you can add something and correct me. So it's a really good question, Memory. It's a very important question because, Mira, if you allow me to say, all the data showed that HRT was associated to a higher risk of breast cancer and other cancers, maybe not only the estrogens, but also the progesterone and different cancers. However, more modern beta data show that this risk is actually really, really minor and very, very low. And the guidelines are starting to say that the benefits may overcome the risk. The benefits of HRT may overcome the risks. So it is really important not to say, oh, you had cancer, you can't have HRT, full stop. It's much more complex than that. There's people that had breast cancer that are on HRT because they need it. You might need, a proper referral to the expert. I would probably consult a gynecologist that has experience of prescribing HRT in women who had breast cancer. But I think we need to be very careful not to eliminate it because of the benefits of HRT. And in fact, again, the guidelines are being updated and it is incorrect. And I find it quite shocking and discriminative to say, no, you can't because you had cancer. So from the infectious disease specialist, as if I declare my conflict of interest, I'm not a gynecologist, but I see a lot of women because of the service that I work in that are coming with that question. And I think we need to be updated, and the guidelines are being updated and there are experts that have experience.
Thank you. Thank you, Martha. And thank you, Memory, for raising this very important point. Another question for the panel.
I would like to add, Martha said everything correctly, but I would like to add that there is a non-systemic hormonal therapy in vaginal form, which can be used by women, even by those who take systemic menopausal hormonal therapy in the form of vaginal gel or the.
Yes, yeah. Thank you, Mira, for this. Can ART cause lack of libido?
This is a really difficult one.
Mira, you might know something a bit more scientific. I'll leave this to you if you don't mind.
Thank you, Martha. Thank you. In fact, no, it is not studied, or the results of some studies are contradictory. So some research studies write that some ART can reduce libido, but they are mostly related. It is mostly related to other chronic comorbidities. And menopause itself can reduce libido. It is one of the symptoms of menopause, reduction of libido. In this period, women are anxious, are nervous, because sexual life is part of their life. And some of women have fears. There are some recommendations about prescription of androgens, but you need necessarily to discuss it with your doctor. There are some studies of use of androgens in some cases to increase libido, but you need to discuss it with your doctor to select, to choose the form of androgens.
Thank you. There is a question from Anna.
Анархан, пожалуйста, ваш вопрос.
Yeah, please, your question. Thank you, thank you. I'm just pressed by chance.
Ah, okay.
I pressed this button by chance.
Okay, thank you. There are very similar questions, so I'm going to kind of group all of them into one. Some of the questions are very much about what Marta in particular, but then also Christine said. When do we need to start taking HRT? In our 40s? When do we start? If menstruation has still been intermittent, is it necessary to start? Am I using this as a preventative measure? Shall I wait so I suffer less from side effect of HRT? What would you suggest?
Mira, feel free to go, and then maybe just because you are really the expert, I feel, and then maybe I'll add a couple of things, but probably not.
Okay, thank you, Marta. I will begin, and if you want, you would add. This question is very specific for women living with HIV. For instance, in my practice, I had women who did not menstruate for a long time, but it was not related to the reduction in hormone production. That is why it is important to talk to a woman, to collect history, medical history, family history. In principle, there are no specific hormones in perimenopause which can show that a woman has started a menopause. As I said, an FSG can be normal. It can go up and down. And that is why it is important for women who are younger than 40 and who have some irregular menstruations. They should pay attention to it. They should visit a doctor and ask what to do. So they should have a blood test for FSG with the interval of 4 to 6 weeks, and then we can diagnose it. Is it ovary insufficiency or early menopause, preliminary menopause? And we need to test women for another hormone, which can demonstrate the deficit of follicles in the ovaries. Ultrasound test should be conducted, and only then a doctor can prescribe hormonal replacement therapy. And as I said, each of these stages is characterized with a specific regimen of prescription of hormonal therapy. It can be a cyclical, it can be monotherapy with estrogens, estrogens. If a woman preserves uterus, she should use progesterone to cover endometrium because she risks to develop an endometrium cancer, especially after 50 years. Also, there are now many transdermal methods, hormonal replacement therapy methods, which do not affect liver functions and kidney functions. And Marina asked what a woman should, a woman asked that she use Mirena spiral, and she had hot flashes, and she should add estrogens to reduce hot flashes. Yeah, that she should reduce hot flashes. So, and when she uses this spiral and estrogen hormone, she can improve her quality of life.
Thank you. Thank you very much. I have only 2 minutes left, and I would like to ask each of our speakers to leave us with some pearls of wisdom when it comes to understanding the complexity of women's health as they're aging with HIV. What do we need to do? You literally have 1 minute each, even less. I'll start with Linda. What do we need to do first?
Can you repeat the question for me when you said a minute?
So the question, well, it's not a question, it's really leave us with even 1-2 keywords or something about understanding the complexities of women's health when it comes to women aging with HIV. What do we need to do first?
I'm going to repeatedly say that we have to figure out how to individualize care for the women's lived experience, and her clinical experience has to be tailored care for women.
Thank you. Marta?
Yes, I fully agree with that. I love the individualization of care. That is the answer to the question before. When do I start HRT? You start HRT when you need it. But the problem is that we need to talk about it. We need to make sure that women living with HIV feel comfortable about talking about themselves, talking about their health and their need at any stage of their lives. This will help us with individualization of care, but it's everybody's responsibility to make sure that this is the comfortable area where we all should be.
Thank you. Mira?
I also support colleagues, but I think that our region, Eastern Europe and Central Asia, is in a quiet period. We do not have any new studies. It would be good if we could use our regional data that we would be able to use. Because now we are using the experience of other countries and regions. It is important. And second, it is important to train doctors, because the issues, the considerations of menopause should be in the interest of each medical specialist, irrespective of nosology.
Thank you, Mira. And finally, Christina?
I just repeat what I've said during my conclusion. I think that we have to be proactive. And proactive means that there are now new tools. We have to use everything. And we have to help our women in taking their health in their hand and change their attitude. And instead of thinking that everything is in a, you know, it's unchangeable because it's the nature, but just doing something new.
Thank you. This is a very important point. Let this be the beginning of a conversation rather than the end. Although we are ending this webinar now, I think really what we learn today is an opportunity for us to start really putting into practice what we have learned today, and make sure that indeed we can talk about women's health from a different perspective, and we can make sure that women are driving any conversation, any decision, and also clinical trials, maybe. Thank you very much to our amazing speakers, Linda, Marta, Mira, and Christina. Thank you for really being amazing, and you always are. Thank you to everyone who took the time to learn and understand a little bit more to what it is living with HIV for women, but specifically aging. Thank you to my colleagues who work, Natalia and Apostolos, who worked really hard to make this possible. And thank you to our sponsor as well, because without the support of Merck, Sharp and Dome, we won't be able to undertake any work on aging with HIV. Thank you. And I really hope to be able to see you again soon in another webinar to talk about women aging with HIV. Thank you.